bear with us just a moment on Zoom, or otherwise we're got a little late start due to a previous committee, and we'll get started shortly. All right, we can go on and call this meeting to order, the Special Committee on Access to Quality Healthcare. Thank you, committee members, for being here. And I know we have Chairman Nix and Chairman Todd Jones online, if others, and Representative Fry. Thank you all for joining us. Thank you all for being here. Sorry about the tardy start from the previous committee, but we will get going now. We have one bill to consider today, House Bill 1351. Chairman Knight, if you'd read us your LC number. And the one we're working off of, make sure everybody has a copy, LC 338985. LC 338985. But we'll get those handed out. All right, and how about Kaylin, will you take Chairman Knight one just in case we have to refer to a line, take him a copy as well. Thank you, sir. Begin whenever you're ready.
Thank you, Mr. Chairman. Members of the committee, the issue before us is not a new one. If you'll remember 2 years ago, the House led on a number of healthcare issues, including the fight against rising prices, non-transparency, particularly within the industry and the PBM industry. If you will remember, we had a bill 2 years ago passed through the House. That bill was basically the heart of this bill. It did have some preamble language. It also had a study language and directed DCH to do a study. So I want to give a little perspective in history. That bill passed the House, got over to the Senate. Upon getting to the Senate, DCH contacted me and said, look, we are going to engage. We're going to do a study. This was done by DCH. Will you pull the bill? And that's at that point where I pulled that bill, and it was about to be heard before the Senate Health Committee. Okay. And so that gives you perspective of where we're at. So the heart of that bill, the carve out portion, is what we're looking at today. And again, this is a HB 1351. And please forgive me as far as the technology here, but today, Terry, you said hit a certain button. I'm not sure here we go. I guess I can hit a button here to move the screen. So here we are today. Uh-oh, not working. See if I can move it. Here we go. Georgia Medicaid CMOs. Where are we today? We have 3 managed Medicaid programs here at Peach State. As many of you remember, we went over some of this. Peach State is owned by Centene, number 24 on the Fortune 500 list. Centene also recently purchased what was the 4th managed care Medicaid program, which was by WellCare. PBM that is administering their RX benefits is CVS, which is number 4 on the Fortune 500 rankings. Our second Medicaid group is Amerigroup. It's owned by Anthem Blue Cross Blue Shield. It's 23 on the Fortune 500. PBM administering their prescription benefits is their own affiliated IngenioRx and CVS. And then the third one is CareSource. While it's a non-publicly traded managed care organization, but it's one of the largest Medicaid managed care plans in the country. PBM that is administering those benefits is Express Scripts, which is owned by Cigna, and it is number 13 on the Fortune 500 ranking. This is not new. This is what we've been dealing with for years. That's what this body in Georgia has been leading on, is trying to address the issues and the behavior of managed Medicaid care companies. As you know, spread pricing. We've dealt with that issue. A history has been there of charging the taxpayers more for the drugs than the pharmacies are reimbursed. If you remember that this House, through the appropriations, ordered language that was included in the House budget language, and Georgia was one of the first 3 states in the nation to uncover spread pricing. We've also dealt ad nauseum with steering, a very heinous practice in which the PBMs are steering or pushing the patients into their downstream assets. And what's unfortunate is most of them, and a lot of them, are cancer patients, HIV patients, and the most chronically ill patients that are out there needing, again, the most help and care. We've also dealt with, and we've seen this behavior, and we dealt with this 2 years ago in our bills, retroactive fees being assessed to the pharmacies. Let me remind you, this is when a pharmacy completes the transaction, and later on, there's a retroactive fee. The PBM goes back in after the transaction is completed and adjudicated and grabs some money back. That is retroactive fees. And that's what's never told. And that's what we're finding out more and more, that they're still in this heinous practice is still going on. And the PBM and the managed care affiliate pharmacies are being reimbursed more than the independents. Again, I will report you back to what we found in 18. This is from the study. You'll see that in 18, there was a $48 million Peach State spread pricing. In other words, that was where they were charging the state $48 million more than they were actually reimbursing the pharmacies. 2019, $38 million. Again, this was the language this House put in. We were one of the first ones to address this, discover it, and address it. Spread pricing. These scandals are going across the country. Centene currently in settlements for the spread pricing. If many of you knew that Ohio, what we were referring to, and what we were in, I was in conversation with some of those folks as they found this. And that's what we began to work on. Centene, they currently have $88 million in Ohio set aside for Ohio settlement, $55 million for Mississippi, 56 for Illinois, 15.2 for Arkansas, 26 million for Kansas, 21.1 for New Hampshire. Centene has set aside over $1 billion to cover the settlements with the states, and the attorneys listing and D's have been engaged in Georgia to investigate the spread pricing here. Where we're at, managed Medicaid today. So this General Assembly has made it very clear. We've shouted it from the highest hill that we could, that spread pricing is prohibited through our laws. We've addressed and outlawed retroactive fees, prohibiting those. We've addressed the issue of steering. We've also, in the past, with our MAC prices, we've tried to address the underwater reimbursements that the managed care organizations are subject to Georgia's MAC pricing laws to try to prevent this. But in all that we've done, this body and every one of these members up here, I believe, have unanimously supported these issues, despite our best efforts and despite the laws that are on the books. The games continue and the games persist. There are examples, and you'll hear from some pharmacists later on testimony about our community pharmacies that are under siege with underwater reimbursements. Access to healthcare is important, and especially when it comes to serving the most needy populations in Georgia. We often think about rural, and again, this is rural, but it's also the underserved that is right here within miles of this capital. And I'm sorry I couldn't get one of the witnesses that testified a couple of years ago. We couldn't get a hold of him in the schedule to permit for him to come back. But if y'all remember Thomas Jesus, he lost one pharmacy, and he's sitting here serving the most needed patients in Georgia within miles of this pharmacy, the managed Medicaid, and he is getting driven out of business. He's already closed the pharmacy 2 years ago. He testified before this committee. So there are examples from Decatur County, Toombs County, Gordon County, Webster County, South Georgia, Northwest Georgia, Southwest Georgia, and there's more, but these are the ones that we've got testimony for. Just an example, independent pharmacist from Decatur County, 3,500 prescriptions negatively reimbursed in the past 6 months, loss of $21,000. Independent pharmacist in Gordon, 3,700 scripts negatively reimbursed in the past 6 months, a loss of $27,000. Webster, 1,068 prescriptions negatively reimbursed in the past 6 months, loss of $3,100 and some dollars. Toombs County, 10,500 prescriptions negatively reimbursed in the past 6 months for a loss of $68,000. Again, these are the contracts, the managed Medicaid benefits that are administered by these companies. And we're asking, and in a time where we need more and more healthcare, access to healthcare, these companies that we are contracting out through the state are continuously driving profits and driving our providers out of business. And we need more access, more access. You wonder what it looks like from a cancer patient point of view? I know many members on this committee, we address that. Remember Dr. Dillman and the testimony that we had last year? I know Sharon Cooper was chairman. That was one of the most hideous things we have. Well, this is an example that's still going on today. This is a care source. Again, must fill through specialty pharmacy. These are patients who are going to the cancer doctors, and the drug is sitting on the counter, okay? And they're being forced to these specialty pharmacies, and they're being forced weeks and weeks and weeks to get drugs, and they run around. Again, another example, must fill through specialty pharmacy. Many of you heard about some of the narrow networks and what's going on here. Amerigroup, one of the managed Medicare programs we have here. If you look in the yellow I've highlighted, you're starting to see these narrow networks within specialty pharmacy. This is off the website. GeneRx Specialty Pharmacy and 12 Stone Health Partners. That's a pharmacy that is out of Tennessee. Two pharmacies is the network, and they're steering our cancer patients that are part of the Amerigroup Managed Medicaid program. They're steering them there. That is wrong. So either you go through Amerigroup or you go up to Tennessee to a Tennessee specialty pharmacy. We're going to hear from a patient shortly. He's going to give testimony on this. Managed Medicare retroactive fees. This is heinous. We know that we've heard this from our constituents. We've heard this across the nation, both in Medicare. Guys, this is happening in our Medicaid, managed Medicaid programs here. Medicaid Managed Care Organization's December 21 post. There's an example, posted adjudication retroactive fee of $219 for a total drug loss to the pharmacy of $235. They lost $15 at the counter when they did it. And then again, the retroactive fee that was later on, that was basically went back and charged, took another $219 back. Another example, December of 21, after the adjudication, retroactive fee of $10 for a total loss of $64 at the point of sale. Again, these are examples of where we are wanting to provide access for Georgia Medicaid patients. But yet, when they go to some of the places where the healthcare is most needed, these pharmacies, this is what the pharmacies are getting. And it's hurting our patients, and it's drying up access because it's running independent pharmacists out of business. So what's left? Only the managed Medicaid assets. There are many more examples, but the practice continues. Many of you, as I referred to the state study, and I know probably some of you have been contacted regarding this, but I want to point you, scenario number 2 is probably the most realistic scenario. And if you look at that, it's actually a state savings of about $1 million. That is the most actual, that's the most realistic scenario that came out of the study. And if you look at many of them, there was actually savings, and the ones that even listed a loss was minimum. That's what the study showed. Guidehouse study, this was the study. It was completed in November of 2020. Most likely scenario again is a $3.9 million savings with $1 million savings to the state. Savings is based on potential increased rebates and lower admin fees, and the expenses that are increased are the dispensing fees. It's a fair dispensing fee. I'll remind you that CMS, this is what is CMS rules on fee for service. This is transparency. It's the cost of the drug. Remember the study and the survey, the Myerson study that CMS does? This is the best actual benchmark that we have of cost out there. And then plus a reasonable dispensing fee. That study, though, failed to look at current retroactive fees and the practices that are similar to spread pricing. That's the fallacy in the statement. I mean, in that study. I'll remind you of the examples that I just told you about and that you'll hear. The study did not take into account the retroactive fees that are coming after the adjudication of the claim. We're asking for a carve out. You know, simply put, the PBMs and managed care organizations, they can't be trusted to administer our prescription and Medicaid managed care for retail pharmacy. We want to put back in a fee for service. We already have that program. I think it's for the aged, blind, and just, yeah. So we already have that. Again, the reimbursement is based on the NADAC, National Average Drug Acquisition Cost, plus the $10.63 dispensing fee, which is based on the average cost to dispense. It's transparent. It's there. It's the cost. And everybody is subject to this. Everyone. What this does is it brings transparency. That is the largest and most sought after aspect that we are fighting on the high cost of not only healthcare, but in particular prescription drug benefits. It's transparency. How many bills have we passed that are getting back down to what is the actual cost versus artificial list prices, versus, you know, what these hidden charges are in contracts that we can't see? Again, this stops through Medicaid management. If we do this and carve this out, it stops those retroactive fees. It stops the steering. Everybody gets to participate, especially the pharmacies that we're depending on in some of the most underserved areas in Georgia. Not only rural areas, but areas that are within miles of this capital. That's access. And we have more providers out there, more pharmacists that patients can actually go and talk to. That's patient access. And I dare say it's better patient outcomes, healthcare outcomes. Because when a patient gets to see a provider, whether it's an emergency room physician, their physician, or their pharmacist, they are seeing a person that gives healthcare. And that, my friend, is going to result in better healthcare outcomes. With that, Mr. Chairman, I'll be happy to answer any questions. I know we have some testimony, and in particular a patient that is zoomed in. I'll be happy to answer any questions.
Sure. We'll have a couple of quick questions if needed. I know we have others waiting online as well. Representative Prince.
Thank you. Thank you, Mr. Chairman. Thank you, Chairman Knight. You mentioned the bill being pulled from the Senate last year.
2 years ago, yes, sir.
Yeah, why was that?
What we had done through the bill that passed through the House, if you remember, it was the same heart of the bill, the carve out, but we needed a study. So the bill did a couple of things. It had a preamble in it that actually started listing the poor health outcomes of managed health care. But it also it also had a provision in there that said you will do a study. So that's at that point when we got over to the Senate, I got the call from DCH that said, hey, we're going to engage in this study. Will you pull the bill? We're going to go ahead and do it. And that's when I agreed, because they were engaging in the study. That's when I agreed to pull the bill.
Okay, quick follow-up, just
Sure.
quick. And based on that study, the recommendations were that basically if we took the administrations out of the PBMs and MCOs, that someone else could do it better. Who would administrate?
That's what
administrate?
we're doing now. That's
Who
through
would
the
do
state. We have.
The state
under-
would?
Yeah,
Okay.
the state, because we have two basically prescription drug benefit ways that we are administered under the state Medicaid. Okay, one is for a fee for service. For instance, you're a pharmacist, you get reimbursed for the cost of the drug plus the reasonable dispensing fee.
That's for
Everything's-
age blind and
Yeah,
disabled.
we
Is that
currently do that right now.
Right.
So all we're doing is moving from the managed care organizations, in which we contract out with them, pay them. They're the ones that set the contract. They're the ones, and we pay them a per member per month, capitation rate, and they handle it out. And that's where all these publicly traded companies that we're mentioning and their downstream assets are carrying out these what we consider very, very bad business practices that are hurting patients.
Is the goal of your bill more to save the state money or to improve the care, or a little bit of both?
I think, Chairman, that's a great question. I think it's all of the above. And I think in the end, we've seen through this study that the bill is either neutral, or even if it has a tiny bit of cost. I mean, I'm talking about immaterial, but more so the most likely scenario is a savings. Okay, even though it's small, what it does is it finally provides the transparency that this General Assembly has been looking for. It is the transparency, and when we have transparency and we have better access to all pharmacies, all providers, then we have better patient outcomes. And we, the General Assembly, can better look at, through a transparent system, what the true cost is, versus if we turn it over to the managed care organizations, that is protected under those, remember, those proprietary and confidential contracts that we no longer can see what are the terms. So I think it's both, Mr. Chairman. It's all of the above.
Chairman Corbett.
Thank you, Mr. Chairman. I think the slide showed, we were talking about the savings, $3.9 million with the state being 1.2 of that. So the 2.7, does that go back to the patient, or is that split between the patient
I
and
think that's
pharmacy?
the federal, because as you know, with Medicaid, there's federal reimbursements, there's federal money and there's state money.
Okay.
Thank you, committee. Chairman Cooper.
What is the dispensing fee now?
The dispensing fee under
Age blind and disabled.
Is
No.
that
No,
under the managed care organization prescription, who knows?
I think it's supposed to be a little over $1. Do you know? Less than $1?
Well, I mean, you sit here and saw this, whether they however they price it, after you have the the reach back, okay, they're losing money, period. It doesn't matter how you put it on, you put money on the cost of the drug that's being reimbursed or a dispensing fee under these contracts. It doesn't matter. When you combine them, what we're seeing is a loss to the provider.
Okay. But in this one, it says the dispensing fee will rise to over $10. If you're taking away all the clawbacks and all the problems they have, then all of a sudden, isn't that a pretty big jump?
I don't think so.
Because you're talking about their losses will
Well,
be gone.
one, I would tell you, we're already doing this on one side of the house. Okay, so in the age blind and disabled, we're already in a fee for service structure.
But I
Okay.
thought we did that because they took more time with the physicians. They're supposed to take more time with the pharmacists needing, counseling and all. So there was a reason for, a higher fee.
Well, I think the same could be said on this side. I mean, we have patients where the only healthcare provider in some of our, what you and I know as deserts, in parts of Georgia. I mean, healthcare deserts in parts of Georgia.
Oh,
That pharmacist is perhaps the only healthcare provider that we know is in some counties. So there is a lot of counseling, whether it be under the existing aged, blind, and disabled, or whether it's somebody that's going in and getting counseling on diabetes, on medicine testing, other interactions with drugs. I mean, again, there are people who do this for a living, can tell you the amount of time that they spend with these folks.
I believe we have some people
Oh, wait a
from the
minute. I have
field.
another question if I may.
Sure.
Okay, but the other question I have, this doesn't just affect independent pharmacists, and I can see, the need in rural areas and so forth, and they're becoming rare birds. But doesn't this just give a big boost to people like Walgreens and, the commercial ones who are already making a huge amount of money? And when you go in the bigger areas, you don't get any service or extra care from the pharmacist.
Well,
I don't have one anywhere near. I said they're becoming,
Well,
a thing of the
I think that's
past.
what I think it's part of the reason here is access to healthcare. But Chairman Cooper, you make a good point, but again, this fight and this 5-6 year battle that we've been in to address this issue, what you're seeing is that all of this profit, all of the steering to downstream assets, all of behind the scenes in these contracts, that it is costing us more, okay? And we don't know the details. We can't get to the contracts. We can't get to the transactions. And so what we're saying is, and with this study, and this was independent, it was a DCH, they're saying when you compare the two, okay, this is what falls out of the study.
all right.
And quite frankly, at best, it's a wash, and that includes the fees or the dispensing fees. It's a wash, but I would tell you what we've been trying to get at is transparency and patient access.
Okay, I just have a little trouble
I-
with the fact that, patients being steered to go to Walgreens or being steered, to use these big, mammoth pharmacies and stuff where they don't get any care and,
Well,
they're
This
made
bill
to use
would
them.
decrease that if they're
Yeah.
out of the loop, right?
yeah,
or
and
eliminate
quite
it.
frankly, Chairman Cooper, I think Chairman Newton makes a great point. A lot of these patients don't have, through what's going on with these in the managed Medicaid, they don't either have an opportunity or you have these other options. In other words, choices of what we were talking about in the last couple of years, patient choice to go to a independent pharmacist. This will allow those independent pharmacists to engage and to serve these patients where we know that they're getting that firsthand care versus walking into maybe a larger, commercial type box or even more so being steered to mail order, where that's also not patient care.
Okay.
We do have
But just
several
make-
others
wait.
to speak that have signed up to speak. If
And
we
I-
can have just a couple of brief questions from the
Yeah.
two committee members still. Chairman Houston.
Did you say that, I missed this, that the pharmacists aren't getting reimbursed as much as the state wants to pay, would pay them? What did you say about that?
That was, I think, in regards to what we were finding with the spread pricing. Is that what you're speaking
Yes.
of? Chairman, to my good friend and sweet mate, if you remember that language that was put in the budget a couple of years ago, wanted to address spread pricing. And that's where the state was
Okay.
actually found out that we were reimbursing the managed care, the PBMs, okay, say $10, but they were only then going and reimbursing the pharmacies, say, in an example, $8 or $7. So that's spread pricing where the state was actually paying out more than what the reimbursement was to the actual pharmacy where the transaction took place.
Okay, well, next question. Okay, next question. Who gets, if we change to this, who gets the rebates?
The state.
All of them?
Mhm.
Do they get all the rebates that are given from the pharmacy now?
No, I don't think they
Do
do
the
under the managed care.
managed care, do the managed care people get any of the rebates?
Nope.
Is the question, do the CMOs get the
Do the
rebates
CMOs get
now?
Under managed Medicaid.
So currently rebates flow Currently, rebates flow back to the Department of Community Health, the main rebates, but there are supplemental rebates. And what the study contemplates is DCH would have the ability to negotiate supplemental
Okay,
rebates
so they could
that
get
would
this,
also flow back to the
DCA could
state.
get the supplemental rebates. That's
absolutely
what I
right.
wanted to ask.
Thank you.
Okay.
Thank you. And we have Representative Fry on the line for our last question, and then we'll get to the other presenters.
To my
And you-
friend and old high school friend, we went to high school together.
Played football together, Chairman Knight.
We
Don't
did.
leave that
Good.
part out.
Yeah, the good times. Don't tell too many stories, Spence.
Thank you for bringing the bill. I've got a question. Thank you, Mr. Chair, for allowing me to ask a question, but I have a question about what you described as like a clawback. And could you talk about that just for a second, saying like the pharmacist dispenses the medicine and then the PBM comes back and charges the pharmacist more than they
Yeah.
expected? Is that what you're talking about?
Yeah, it's basically after the fact through the contracts. Let me see if I can get this, get my presentation back up. Terry may have to.
And then real quick, as an addendum, Mr. Chair, what are the consequences if they don't pay that clawback fee?
Well, I mean, I think it's automated. They reach in and grab it. It's part of a complicated process. And so it's after the fact. And again, it's retroactive fees. Many of us have heard this also on the national level of DIR fees, okay, in which it's after the adjudication of the claim on the back end, post adjudication, they reach back in and through a reconciliation process, they say, hey, you owe us this. This is a fee after the fact. So it'd be equivalent to you and I walking into a store, making a transaction and a purchase, and then all of a sudden, the store 3 weeks later or whatever gets a bill from, I guess, the manufacturer of the product saying we're going to take some money out of that transaction. Well,
Okay.
Unfortunately, I think they are the ones that are coming up with this, Mr. Whip. So, but that's what you're speaking of, Spence, is the retroactive fees. And we're finding that, again, many heard of it as DIR fees and like Medicare at the federal level, but now we found it and we know it's happening in Medicaid, Georgia State managed Medicaid.
Well, thank you, Mr. Chair. I appreciate you bringing this bill.
Thank you.
Thank you, sir. There are no more questions right this moment. I know we have some others to speak.
Yeah, absolutely, Mr. Chairman. I know we have one of the patients that.
Is that who you'd like to go
patients.
next?
Yeah,
Okay.
yes, sir. If would permit it, she's been very patient and hanging in there with us to give her testimony.
Certainly. Is it Miss Wells online? Stephanie Wells, if you could introduce yourself and go ahead.
Absolutely. My name is Stephanie Wells. I am a breast cancer patient. I have been fighting with and dealing with Ingenio Pharmacy for about 2.5 years. One of the drugs that I'm prescribed by my oncologist is a drug called Verzenio. It is my required chemo medication that has been very effective, but my insurance, which is Amerigroup at this point, I'm under Women's Health Medicaid, requires me to use their specialty pharmacy, which is very problematic because they're not here. So when I run out of the medicine, I have to wait for a delivery. And they give me about an 8-hour window that they want somebody to stay at the house to sign for this medication. As I've continued to battle them, because they gave me 2 months that they let me get it at the pharmacy that my oncologist is at, that I'm at every week, was so much more convenient when I could get it there because my oncologist does have it. They did not let me get it after that and said I had to continue using theirs. I can't leave somebody home for 8 hours. That's unrealistic. When I asked about using a local pharmacy, particularly my oncologist, they told me I could use their other pharmacy in Tennessee, and I live in Hull, Georgia. So that's not even remotely realistic. When I've talked on the phone with them, I spent hours of my life wasted on the phone with these people trying to get this approved. And I get a continual runaround of, I need to speak with their appeals department, but there's nobody in their appeals department. I need to fax their appeals department. I didn't even know people fax things anymore because it's 2022. Email, right? Isn't that what people use? I offered to email, I offered to fax. Then I was told, but I said I wanted to speak to a person. I always get put up the line. I can never get a person that can help me. The last time we went through this was 2 weeks ago. I went without medication for a week and a half. No meds, because they would not send me my drug because we were battling about where I could get it. It's not the first time I've had to go without it because the pharmacy hasn't got it to me on time. It's why I've asked that they move it to my oncology office, because I can get to them every day. I'm there once a week. I won't run out if it's there. So they add to my constant stress level because I'm continually battling them. And when I'm constantly having to battle them and spending 2 to 3 hours on the phone with them, it's exhausting. Like I don't have enough on my plate trying to fight and win against a stage 4 diagnosis. I have 3 children in my house, and I continue to have to take time away from all of that to continue to talk on the phone with a pharmacy that doesn't care and an insurance company that certainly doesn't seem to care about me. I've listened to some of y'all talk about getting that like care from the pharmacist. And I'm telling you, Ingenio's never given me one-to-one feedback on this drug. The only person who talked to me about this medication when I had to go on it was the pharmacist at my oncology office and my oncologist, because the pharmacy Ingenio would not. They just called and confirmed that they were sending it. So like that's another thing to consider. Like they were not helping me in the slightest. They certainly were not providing me with additional care. The additional care I continue to have to get is coming from my oncology office. But it's incredibly stressful to have to continue to deal with this every single month for a drug that does not even last a month. It lasts 28 days and then I'm out. What I don't understand is why it continues to come down to profit and not my life and my care and what I need to be happening for a medication that I could get locally if they would allow me to. But they continue to battle me every month. Now, I will tell you, I'm a very stubborn person, so I'll continue to battle them because they will not win. However, I should not have to, because my life is valuable and other cancer patients' lives are valuable. And we should not have to be fighting something so that someone else can make a continual profit. Like that's beyond ridiculous and continues to happen regularly. So it's very exhausting to me.
Thank you very much for your, thank you for your being willing to meet with us today and share with us. And we certainly wish you the best as you and it looks like you are a fighter, and you keep up that work. Okay.
Yes, sir.
Thank you for being with us today, Ms. Wells.
Thank you.
Next to speak, Jesse Wethington. If you could just introduce yourself for the group and
All right, while Ms. Buchholz is passing that out, I'll go ahead and introduce myself. I am Jesse Wethington. I'm here today as the Executive Director of the Georgia Quality Healthcare Association. That is the trade association of managed care MCOs that serve our Medicaid population. Heard a lot about those today. This is a bill that we're all familiar with. I think it wouldn't be a late February in session if I wasn't up here talking about a Medicaid carve-out bill in the Special Access Committee. And so this is one of the things we want to talk to you about today. The study came out, that's what's just been distributed to you, some excerpts from it. But this bill's really about a couple of things. And, I'd like to boil it down for you. It's about brand name drugs versus generics. It's about dispensing fees. And then it's about, this whole issue of transparency or not. We've heard spread pricing and steering brought up and talked about a lot today. So, if ever a bill needed a fiscal note, and if it wasn't clear, we're opposed to the measure. We would like to continue to serve these populations through the program as is. For several reasons. So the study was brought up today. We want you to have that. If ever a bill needed a fiscal note or there was a reason for the Fiscal Note Act, House Bill 1351, I submit to you is a great example of that. There's a lot of moving pieces to this. So, take a look at that Guidehouse study that's in front of you. Scenario 2 is highlighted there on the first page, but you can see all 6 on the second page. And so, take a look at all the moving pieces here. So if you look at this, the scenarios do show some potential savings, some show a cost, but that's only if you ignore the premium tax impact that would occur if this bill were to pass. And so you do need to net that out to actually get the true fiscal impact of a concept like this. The bill is a little different than it's appeared in previous forums. But take a look at that. There is no savings. One scenario, number 5, shows a savings potentially of $100,000. I submit to you that's a drop in the bucket in the world of Medicaid. And I believe the study cost approximately $50,000 to do. So you've already given a little bit of that back. The top line thing we'd like for you to really look at, and again, what I think this really is about is dispensing fees. So you can see a pretty dramatic increase in what those aggregate dispensing fees would be under this bill. And so the reason for that, as has been alluded to already, is the transition away from different pricing schedules towards the NADAC, National Average Drug Acquisition Cost. If you're talking about a reimbursement for a pharmacy agent, there's 2 pieces to that. Typically, there's the ingredient cost. There's all these different indexes. NADAC is one of them. AWP, MAC, you've heard about already, or others. But there's also the dispensing fee. So that's, to cover the overhead, the cost of the, the pharmacy to have the lights on to see the patient, take the time to talk to them. Those vary now by CMO. They range as low as like 30 to 50 cents for some. I know that some are paying a heightened dispensing fee of $1 to $1.50 to targeted independent pharmacies. And of course, the NADAC drug dispensing fee is $10.63. And that, will be adjusted periodically, but that's what it's been at for the last couple of years. So it represents a pretty dramatic increase in dispensing fees for serving this population. And we really think that's really what the crux of this bill is about. There will be a change in generic utilization as well. That's one thing that you typically see in sort of the results and formulary management that we're able to achieve as managed care organizations or through pharmacy benefit managers. We tend to have very high generic utilization rates. And of course, generics typically don't have rebates associated with them because the list prices are low enough to not necessitate that. There would be some change in the ability of rebates to flow through here. This is put into the study that's in front of you. However, it's not enough to offset some of these other moving pieces that would come out in terms of the increased dispensing fee, the loss of premium tax revenue, the ability to match that to download additional FMAP if you put it back into the program. And so we don't think it's realistic to say that there will be a savings to the state here. That may be something that you want to do as a General Assembly. However, House Bill 1351 is not a vehicle to achieve savings. Certainly, there can be a question of what a reasonable dispensing fee is. As Chairman Cooper mentioned, this dispensing fee would kind of go across the board out to everybody who's serving Medicaid. So it would wind up being a windfall for some pharmacies that you may not agree particularly need such a windfall. It's our contention and suggestion that it would be better served, the General Assembly, the public, and the Medicaid program would be better served by targeted dispensing fee increases that would go to independents, sole community pharmacies, providers in rural areas that you could do through the appropriations process. Many other Medicaid providers have come in the past 10 years and gotten rate increases done through the appropriations process. The pharmacists have not. And I would suggest that perhaps, they are overdue to do that. And we would encourage them to do that instead of this. And we also talked about, there was a lot of talk about spread pricing, steering, all that has been addressed. You have comprehensively treated on PBMs, regulating their conduct, both on the commercial and the Medicaid side in the state. Many of those things are still being worked out or implemented at the regulatory stage. So we would say, let some of those things play out, deal with them through the enforcement or regulatory process. Don't use examples like come in here and tear up the whole program. The other thing that the other result from this would be that you are denying Medicaid patients a choice of different formularies and networks now, putting them in a one size fits all box. And additionally, on the back end of this, DCH is not going to administer the fee for service pharmacy benefit internally to the government. They have a PBM. It is Optum. I believe they're the fourth largest company on the Fortune 500 because they have to have vendors to run these benefits. The differences are there's no network management there. Rebates were brought up in the context of managed care. We can't get supplemental rebates. So that is an issue. And you see that treated here in the report. Lastly, this wouldn't show up in a fiscal note per se, because it's not a direct impact to the state. But there is a big impact to 340B safety net pharmacies that's contained within this. The reason for that is, so if you get a 340B drug dispensed through your 340B pharmacy, your provider, if you get reimbursed by fee for service Medicaid for that, you get the 340B price. They're not allowed to pay you a premium on that. You can't make a profit. We pay the commercial, the negotiated price through the PBM. And so 340B pharmacies are able to generate a significant delta on that. It's a big profit driver for community, large community hospitals, rural providers, community health centers. So please don't ignore that. We would say, look before you leap. There's a lot involved in this. It's a very complicated issue, but we would say that a carve out is not the way to go and very much are opposed to this legislation.
Can just real quick, and I appreciate the Guidehouse study you had, and you got scenario 1 and 2. I'm just curious about 2 questions. One is the difference in the rebates in carve in and carve out of $105 million in these two. What's the reason that the rebates are so different? Or are they so much higher in the carve out?
So we can't generate supplemental rebates. So those are rebates that are over and above what a manufacturer has to give to participate in Medicaid via federal rule. So supplemental is what fee for service Medicaid is able to go and negotiate for. They have a preferred drug list too. They don't do network management, but they certainly prefer or disprefer things based off of the size of the rebate. When that generic utilization goes down, brand utilization is going to go up. There are additional rebates associated with that. So they would theoretically increase under this scenario. So what Guidehouse did.
The rebates would increase, is that right?
Right. Not enough to offset the increased costs on others and the loss of premium tax revenue. And so what they did in the study was they ran like a high, medium, low scenario on what the rebates would look like. And I think they did high, medium, low on generic utilization. So that's why you have 6 different scenarios, although they did highlight scenario 2 as the most likely. I don't have any reason to disagree.
All right, just real quick on these, when I look under carve out under scenario 1, just for example, it says 300.4 million ingredient cost and 211, and then the rebates are 307 million. Is that a ballpark of on $511 million of drugs that the rebates might be 307 million?
I think that's a reasonable assumption based off Guidehouse's methodology. And again, they did a high, medium, low in that. So you see that presented differently through each of, the scenarios 1 and 2, 3 and 4, and 5 and 6.
All right. Thank you. Are there any other questions from the committee for this presenter? Don't see any right now. Thank you, sir.
Thank you, Chairman.
Next, Melissa Rybold, if you could introduce yourself and who you're representing.
Thank you, Chairman Newton and committee members. I'm Melissa Rybold, Vice President of Public Policy for the Georgia Pharmacy Association. There are a few people here, maybe even one of your constituents, and they need more time than me because this bill will help them tremendously. But I just want to tell you, I've been with GPHA for over 9 years, and I used to visit independent pharmacy members in my previous role all over the state. And I always heard the same thing day after day: steering, retroactive fees, and underwater reimbursements from the managed care companies are slowly killing these pharmacies. And you will hear this today. And the Georgia Pharmacy Association and the Academy of Independent Pharmacy are in full support of this bill. And thank you for your time.
Thank you. I see no questions. Philip Howell is next on the list. If you could just introduce yourself, maybe where you're from, and proceed.
Thank you. I'm Philip Howell. I'm from Calhoun, Georgia, and I'm the owner of the prescription shop. And by all rights, I probably shouldn't be standing here today. My pharmacy has lost over $100,000 each of the last 5 years running. And a big part of that is the state managed Medicare programs. And when I talk about reimbursements and stuff like that, it's all based off of my purchase price. I don't factor in, salaries, supplies, anything like that. But for the year 2021, my pharmacy filled almost a little over 19,000 prescriptions for managed care organizations.
Excuse me, when you say managed care, do you mean all
Amer-
managed care or managed Medicaid?
Amerigroup.
The three, okay, the ones we're
Amerigroup,
talking
Peach
about.
State, and
Thank you.
CareSource. And here in my hands are 5,437 prescriptions, 50 per page, that we are reimbursed underneath my purchase price. It represents $40,000 in lost reimbursements. And for those 19,000 plus prescriptions I filled, my average profit was around $3.50 a prescription. Just for reference, it costs me about $6.50 to $7 a prescription in salary alone to fill prescriptions. So I'm losing money on every single prescription I fill. And to make things worse, to kind of add insult to injury, they're still charging retroactive fees. Just this last December, I filled an EpiPen for a, sorry. Just this last December, I filled an EpiPen for a child. My purchase price was $300 for that EpiPen. The managed care organization paid me $207. So right off the bat, I lost $97. Then 3 or 4 weeks later, the effective rate came in and the PBM charged me back $150 on that $207. So my total reimbursement for that EpiPen was about $57. And, my choice, it's like I'm contractually bound to fill that prescription. I cannot refuse it based off of cost or reimbursement to me. So my choice is either to not stock this life-saving medicine for this kid or fill it and lose $250. I filled a Symbicort prescription for a COPD patient. My cost was, it was a generic Symbicort. My cost was $241. I got paid $260. So it seems like on the surface of it, I made a decent profit. But when the PBM came back and took back their retroactive fees, they charged me $204 for that prescription. So I ended up losing close to $200 on that inhaler. And I'm not standing here just complaining about money because I've got 18 employees. I could hire 4 more tomorrow if I could afford it. Easy. The employees I've got are overworked, they're stressed, they're having to do 2 people's jobs. And I'm dreading the day I get the phone call that we misfilled somebody's prescriptions because my employees are having to do 3 different things at once. They don't have time to sit there and focus on what they're doing because I can't afford to hire the help they need to do their job. My customers that come in and depend on us, they depend on our accuracy. They trust our judgment, but it's hard to focus when you're so overworked and stressed. I had to let 2 pharmacists go in December. So now I'm having to work 60 hours a week. I'm a single dad. I got sole custody of my kid and it's hard. I'm working till 8 o'clock every night and I can't afford to hire the help I need to run my business. And I'm asking y'all to support House Bill 1351. I think the NADAC is a very fair price plus the reimbursement. As things stand now, you're asking about dispensing fees. There's hardly any. And even if you factor in dispensing fees, the basis is so low, it doesn't matter. We get reimbursed 30% of my prescriptions I fill for managed care organizations are below cost. That's, and it's hard.
Well, thank you for being here today. I know it's tough to take off, I'm sure. And we do have a question from a committee member.
Okay.
Thank you, Mr. Chairman, and thank you for coming down. it means a lot to hear from people on the ground, and I do thank you for that. So I'm a farmer,
Mhm.
and so some of the things you said resonate with me also, but I'm not a pharmacist. When they come back with this retroactive fee,
Mhm.
what is the rationale behind that? I mean, I can't imagine how comfortable a conversation that would be, or an email that says, hey, look here, I know we agreed to this, but this is what you're actually going to receive.
I don't have a choice in the matter. All the reimbursements are pretty much done electronically. So I don't get the choice of paying them back. They just take it out of what they pay me on the next go round. So it's not like I have a choice in the matter. They just take it back.
So a follow-up, Mr. Chairman.
Sure.
So in fact, you are indeed only just a price taker in economic terms. This is, and you have no say. The second question is closely aligned, if I may. So if you lose money on each Medicaid prescription that you fill, and you still must fill them, would you be more likely or less likely to locate a pharmacy in some of the rural areas where there is a higher Medicaid population, thereby creating additional deserts in healthcare?
I don't think so. I mean, if
That was
well,
one of these leading questions that kind
I
of
believe it
answers
was a statement with the question mark.
Yeah, I
Is
guess
is that not
placed at
true?
the end.
Is that not true?
I mean, well, if you continue it the way that things are losing money, then yeah, because I can't afford to continue filling prescriptions. I'm on the verge of going out of business, and I know I'm not the only one in the state of Georgia that way.
One more.
Certainly.
So if you have no idea, and apparently you don't, what the retroactive fee is going to be, I mean, is there something that you could look and say, guess what? I think I'm going to get paid less on filling this EpiPen. I mean, is there anything that you can do proactively for these retroactive fees?
No,
Thank you.
Nothing at all.
Whip Hatchet.
Well, thank you for coming and testifying and telling us your story. And this question is not for you. So I don't know at what point I need to ask this question. It's more for one of the industry reps that just spoke as a follow-up to what he just told us. So, Mr. Chairman, what do I?
We do have a couple of others to
Okay,
present.
you come back to me.
and, if you don't
Or you
mind.
can come back to me, whatever. So.
Chairman Cooper.
Isn't the retroactive fees, isn't that where on a prescription, if it was filled on the 14th and you put down the 13th by mistake, or isn't that what they're taking on?
No,
No,
ma'am,
that's
it's like
not for that, when they come back and draw money from you.
Clean.
It's like at the point of sale, like our claims are pretty much instantly adjudicated with the PBM. It's like I submit a claim through the computer, and I know what my cost on it is, and the PBM comes back and says, okay, this is what we're going to pay you. This is what the patient's copay is. And I get a total reimbursement from that.
Okay.
That's
Well,
done at the point of sale. Is that right?
That's at the point of sale. And then retroactively, they come back 2, 3, 4 weeks, a month, 2 months later and take back more money than what they agreed to pay me at the point of sale.
Oh, okay. I got it. I mean,
All right.
sorry.
Yes, ma'am.
Did we take care of, I mean, at one point we were having trouble, Greg, you may have to answer this, where they were hitting the pharmacies up for little tiny mistakes, not for the prescription being filled wrong, but
Clean,
a little tiny mistake on what they report back. Weren't they taking and charging money for that?
Yes, Madam Chair. And, you, as a matter of fact, carried the audit bill that strengthened and put a stop to a lot of that.
Okay.
That law in 2020 also prohibited retroactive fees as well. These are not audits. These are not audits related to any discrepancies of claims. What we're seeing is the pharmacy benefit managers are designing and implementing plans that are, incredibly complex.
Okay.
And it's almost arguably a form of spread pricing still. What they're doing is they're reimbursing pharmacies at the point of sale, then they're recouping portions of that retroactively based on really complicated formulas. And so that continues, and that's unrelated to audits and discrepancies.
Okay, basically, it's like getting pre-approved care for the physicians to do some kind of procedure. And then after the procedure's done, saying they didn't approve it or they're not going to pay for it.
That's
Got it.
Chairman Houston.
We have a lot of problems getting doctors to see people on Medicaid. Do you think if we keep this practice up, well, we're going to have pharmacists not filling Medicaid prescriptions?
Well, I already know Walgreens refuses to accept at least one or two of the managed care organization plans. We pick up a lot of customers from them because they don't accept it. And I can see if things continued where a lot of pharmacies decide not to accept the Medicaid managed care plans.
Thank you.
Whip Hatchett.
Thank you, Mr. Chairman. So these managed care organizations through Medicaid are acting as an arm of the state government, correct?
Mm.
And the federal government. So I and my whatever.
Proceed.
Just how is it legal? And it's damn sure not ethical. So I'd love for the industry to answer me there.
That's my
I'm sure
biggest
they'll
question.
say you signed a contract,
Well,
but it's not
much
right.
It's not much of a contract because we don't get to negotiate. They either say, take it, or you don't get to fill anything.
Thank you very much for spending some time to educate us, and thank you for your work in, well, it's not really rural Georgia, but a small town in Georgia, and for what you do for patients. Please hang in there.
Thank you for having me.
Thank you. Jonathan Sinyard. Thank you for being with us today. If you could just introduce yourself and proceed.
Thank you, Chairman. Good afternoon. Thank you for having me here today. As the chairman said, my name is Jonathan Sinyard. I'm an independent pharmacist and an independent pharmacy owner in Cordele, Georgia. So again, small town, not super rural. I'm here today to urge your support of House Bill 1351. Pharmacy nowadays, it's becoming an increasingly difficult arena to operate in, as you have heard countless times throughout the day and prior to today. Mainly, a lot of those practices are brought about by the PBMs and the tactics they employ and the games they play that we're forced to deal with. One of the main areas we see that abusive practice is within the MCO arena, the managed care organizations of Georgia Medicaid. And living in our rural area, we see our fair share of those managed care Medicaid plans, and we're seeing more and more of those patients convert month by month into those managed care plans. And the elusive and opaque practices that they employ are not designed to help those patients they're intended to serve. They're not designed to help the pharmacies that are serving those patients. They're there for one sole purpose, and that's the bottom line, net profit. And unfortunately, most of those profits are being squeezed the life out of those pharmacies using taxpayer funded dollars to do that with. And for example, just to reiterate a couple of those things you've heard earlier, in 2021, looking at our managed care Medicaid claims, we saw 72 from one of the plans that services the largest sector of those. We saw 72% of those scripts filled with a gross profit of $2.50 or less. And again, that's before those retroactive fees are taken out. Of those, 43.7% of them were filled at an actual loss. We were literally paid less to dispense that drug to those patients than we paid to get it on our shelves. And that doesn't even factor in the bottle, the labor, the label, all the intangibles that go into dispensing that medication and doing so properly. Just pause and think on that for a moment. Almost half of the claims dispensed on that were at negative margins. It's not a sustainable model the way they set it up. And on the flip side of that, when you look at that, the pharmacies are struggling tooth and nail for pennies on the dollar for those claims, while you can guarantee those MCOs are making out with a handsome profit on each one of those patients. And again, doing so on the expense of the state. The second largest plan that we deal with in that, we saw similar numbers. 62.6% were under 250, with 25% of those negative. For pharmacies that serve a very heavy Medicaid managed care organization, it's unsustainable. It's a death sentence, as the gentleman earlier was speaking to. you're put in a situation, well, do you serve the life-saving medication to that patient and lose the money doing it? Or do you cancel the contract and leave them to fend for themselves? It's not a model, and it shouldn't be that way in operating in that. And, I don't want to brag about the independent pharmacies and the pharmacies in general, but when you look at the pharmacies and the pharmacists that serve these communities peppered around our state, you will find no greater people more loyal to those communities. You won't see greater love. They're passionate about those communities and those people. That's what drives them to do what they do, to continually go in, day out, up against these mountains they're facing. They're the ones coaching the Little League team, sponsoring the elementary school science fair, making free home delivery to those homebound patients. They're the ones meeting those needs wherever they are. They're the ones opening their stores up after hours when a patient gets discharged. Looking back, I was thinking on this when I was preparing for this. During Hurricane Michael in 2018, our area was hit relatively hard by it. About 90+% of our town was without power for days on end. My pharmacy was open. We were there, generators running, extension cords, flashlights. And why? It's simple. It's for the patients. They needed us and we were there for them. And that's what you see time and time again with that. During the pandemic, pharmacies haven't shut their doors. They may have augmented practices, but they haven't closed their doors. They've found ways to continue to serve those patients. And we should not lean on the managed care Medicaid organizations to be the ones shutting those doors on them. When they survived everything else, they need a chance. Saying that to say, patients depend on their pharmacy, and there will be major harm to those patients in those underserved areas as more and more independent pharmacies are forced to close their doors due to these practices. And it doesn't have to be that way. You've seen the studies, you've seen countless data behind it. This assembly has that power to make those changes. And I urge your support on those bills. Look at the numbers, hear the testimonies, touch base with independent pharmacies in each of your areas. It happens in every corner of the state. Thank you.
Thank you for being with us today. Thank you for coming up from Cordele, and got a great representative from there. Let's see, one last pharmacist to speak. Is it Shelley Williams? Thank you. If you can, we are at a tight schedule at this moment, so thank you for being with us today.
I'll be quick. My name is Shelley Williams, and I currently reside in Ackworth. I'm a Georgia pharmacist, currently employed by a chain pharmacy, former independent pharmacy owner, and I am here to ask you to support Bill HB 1351. I'm a second-generation pharmacist. My father owned a pharmacy for 30 years, so I grew up in pharmacy, and I'm proud to say that caring for patients is just in my blood. My father sold his pharmacy in 1995, and it had been my dream to someday open up a pharmacy on my own. I was finally able to do this in 2015 in Douglas County, where I grew up. While my business grew with more and more patients walking in the door, thanks to referrals and reputation for patient-centric personalized care, the pharmacy struggled on the business side. It's hard to believe, but how can you have growth in patients and growth in revenue, but still struggle? Business practices by PBMs and Medicaid managed care companies is the answer. A large percentage of my patients receive benefits through Medicaid managed care, and these companies engage in steering, charging retroactive fees and low reimbursements, which got so bad I found myself losing money on a huge portion of our prescriptions I filled. Things became so bad that I was no longer able to afford the help of another full-time pharmacist, which made it difficult for me as I was also battling breast cancer at the time. Losing money and being able to afford the necessary staff support, I should have closed my doors sooner. I refused to do so at the time because, as important as fighting for my business was, I felt an obligation to be there for my patients whom I had served and loved. Unfortunately, I'm sad to report, despite my efforts, I was forced to close my doors. Due to the practices of PBMs and Medicaid managed care, it became impossible to stay afloat. My story is not unique, and I'm aware of many pharmacies whose doors have been shut over the last 4 or 5 years. I'm here today, because it is too late for me, you all can still do something to protect the pharmacies in the state that care for members of our community. Caring for Georgia's Medicaid managed care population should not be the biggest risk to pharmacies that are so integral in providing care in Georgia's rural and underserved areas. I know this body has worked to curb the practices of Medicaid managed care companies and PBMs, but the independent pharmacists I talk to tell me that the retroactive fees, steering, and underwater reimbursements still continue. Several are hanging on by a thread. I'm here to help them with their patients, and I hope you will too. Please vote in favor of HB 1351. Please vote in favor of these bills that put the patients and the providers first. Thank you.
Thank you very much for your
Yes.
being here with us today. One final, let's see, Greg Rybold, if you could come on up, and I know we had pulled you up on the spot a moment ago, but thanks for your knowledge, and please proceed.
Thank you, Mr. Chairman. Greg Rybold on behalf of American Pharmacy Cooperative, proud to be here today, proud to follow these pharmacists and the patient who is willing to testify on this difficult issue. What I'd like to do, if agreeable, is to spend the next hour, no, joking. I think big picture here, there was some talk about fiscal node and financial impact. And if we rewind to 2 years ago when this bill was here, the talk was that it was almost impossible to quantify the cost to the state. $90 million, $100 million, $130 million was thrown out per year if there were a carve out. But we've got a study, we've got a Medicaid actuary study, and 4 of the 6 scenarios show savings. Does it increase the dispensing fee for pharmacists? Absolutely, it does. It's based on a federal mandate that says, hey, if you're in fee for service, your reimbursement is going to be at NADAC, National Average Drug Acquisition Cost. It's a transparent drug benchmark. And your dispensing fee is going to be based on the average cost to dispense, taking into account staff, supplies, et cetera. And so we would live in a world of NADAC plus $10.63 dispensing fee. And lo and behold, this study shows 4 of the 6 scenarios, the state saves money. There was some talk about the loss of a premium tax, and I think the study was pretty clear that said as long as the premium tax flows to the general fund, which the study acknowledges that it does, that doesn't come into play. And so right now, the premium tax flows into the general fund. And so it's a non-factor. It doesn't come into play. The study has 4 of 6 showing savings, some of them significant savings. The most likely, frankly, in all honesty, is almost a wash. But the difference is this: how can you spend so much more on dispensing fees for pharmacies and it still be a wash? And the reason is really a simple one. It's corporate fat and it's corporate greed. The study already acknowledged that the state has saved around $50 million a year by eliminating spread pricing. It acknowledges that. But what the study doesn't consider is retroactive fees continue, and it's spread by another name. In Medicaid managed care today, no one can tell you what the cost of a drug is. Is it being properly recorded to the medical loss ratio? Probably not, right? Because they're reimbursing pharmacies one thing, and they're retroactively recouping them. This body has done more than almost any state in the nation, amongst the top in the nation, to try to curb these practices. But so large and so confident are these companies that they just continue to flout it. Retroactive fees continue. Patient steering continues. I got 2 boys, 11 and 8, and every now and then, they're good kids. They listen to their mom more than me, but every now and then we have to take the ball away, right? These are companies that are earning $4 billion a year in revenue from the state of Georgia. They continue to steer, they continue to engage in retroactive fees, they continue to manipulate, and they drug pricing, and they continue to sledgehammer patient access to care. And the question I would posit is, when is enough enough? I think our position is it's time to take their ball away. They can't be trusted. At the same time, these pharmacies are dying and these patients are being steered. A couple of years ago, there was a $100 million dividend. According to an article in Georgia Health News a few weeks ago, a couple $100 million or over $100 million in profits in the last 2 years. They are sucking money from the taxpayers of the state, and they're doing it on the backs of hardworking pharmacists. And so strongly support this legislation and would ask for your favorable consideration. And I thank you.
Do you have a committee question? Chairman Houston. Oh, I'm sorry, Chair Hatchett.
I don't have a question, but at the appropriate time, I would like to make a motion.
Thank you for your presentation.
Thank you, Chairman
Thank you.
and committee.
This is the appropriate time. Yes, sir.
Thank you, Mr. Chairman. Before I do, if I may have the liberty, I want to apologize and say I'm sorry to the pharmacists that are here, that you've had to put up with this as long as you have, and that it's put you in the situation that you're in, and apologize on behalf of myself and probably most of those up here in the state. I hope we can get this rectified, and therefore I would like to move to pass to LC 338985.
Thank you.
Yes.
We have a motion and a second. Thank you, sir. Is there any other discussion from the committee? Any from the committee online? Any discussion? I'm sorry.
One discussion item, Mr. Chairman, if it's appropriate, and I apologize, I missed the first part of this. Made this to the chairman, to the author. Is there any way to move the on or after date less than July 1, 2024?
It's a good question, Chairman Knight.
I think that's a good question. To be honest with you, I think we need to, I would visit that, but I would also visit in light of current contracts. That would be something I would want to run past DCH to see if that could be done sooner than this. That may have been put in there based on current contracts.
Existing contract.
Yeah, existing contracts, but it's a great question, Member Perkle, and one that I will ask.
Okay, thank you. Thank you.
Thank you. Is there any other questions from the committee now? Chairman Cooper.
Okay, I just want to say we could have saved all of us a whole lot of time and solved this problem sooner if we'd just done what I can. Dr. Jean Sumner, the president of Mercer Medical School and one of the most brilliant women about healthcare in the state, said 2 years ago, just do away with the PBMs. They don't do anything. Just do away with them.
Thank you, Madam Chair. Seeing no other questions, all in favor of House Bill 1351, LC 338985, say aye.
Aye.
All opposed, no. Hearing none, the bill passes unanimously. We'll send it on to rules. Thank you very much to all who presented. Thank you for coming here today and the others who participated. We look forward to moving forward. Thank you, committee.